Alrighty, I think we left off with starting to talk about the cardiovascular system. Issues we run into generally that result in perioperative mortalities are generally tied to the cardiovascular system, the biggest one being acute MIs, intraoperatively or ischemic events. So that's why we spend so much time focused on identification of high-risk cardiac patients and what we can do to kind of modify their risk for M&M during the perioperative period. So specific things we worry about from a cardiovascular standpoint, we touched on hypertension. We've got to make sure we pay attention, as I discussed earlier, to what the patient's blood pressure normally is, not what we want a normal blood pressure to be, because a lot of times we have to keep them within 20% of their true baseline, not 20% of the 120/80 that we'd like to see our patients live at. From a cardiovascular standpoint, I think one of the most important things that we kind of don't realize or fail to detect is patients with non-diagnosed ischemic heart disease. So particularly like our diabetic patients and females tend to present with ischemic heart disease in kind of strange ways. So it may not be your classic crushing chest pain. It may be abdominal pain. It may just be fatigue. So I think a lot of times those are the patients that kind of catch up with us in the operating room that we didn't anticipate. We touched a little bit on heart failure the other day, and we'll go into great depth about it. But as we discussed, decompensated heart failure is definitely one of those cases that we don't want to take to the operating room, with unstable angina being the other. Valvular heart disease, as I mentioned last week, we tend to get focused on just the ejection fraction, and we may kind of skim through what's going on with our valve specifically. So another important thing to pay attention to, especially when we start talking about our systemic pressures in our aortic valve. Patients with rhythm disturbances, sometimes we blow them off as being an accepted risk, especially like patients in AFib or A-flutter, but we may overlook the loss of atrial kick in those patients. Other things that we commonly run into, electrolyte imbalances that contribute to rhythm disturbances, particularly when we start talking about potassium and magnesium. We have to think about our patients with cardiac stents and determine what type of stents they have, how long they've been there, what are they on as far as anticoagulation, if any, for those. And our patients with pacemakers and ICDs, we really have to pay attention to what's going on there, where their device is, what type of device they have. And we'll go into depth in that for a later lecture. But it's just something you definitely need to pay attention to and take note of, because it may affect not only us from an anesthesia standpoint, but it can also affect the surgical site. For instance, if you're operating very close to a ICD or pacemaker, you may need to consider doing something that uses a bipolar cautery as opposed to monopolar cautery. You may need to augment the type of positioning that's done, a lot of stuff like that. And then finally, patients with peripheral artery disease. And what we see a lot of times is almost like a continuum. We'll see patients that are either diabetic or have PAD to start off with. And then they wind up getting some sort of infection. They'll get a toe amputated. It's then that they really start looking at their poor peripheral artery status. After that, before things get corrected, it's fairly common that they'll wind up having like a midfoot amputation or maybe a BKA. During that same time period, they will see a lot of vascular interventional procedures. So they may come in and have a whole lot of stents put in, going all the way from their groin to their toes. It was an interesting article, I think, in USA Today last week talking about this exact same thing happening and how we spend hundreds of thousands of dollars on patients that it doesn't make a difference at all. So I think the reps there are doing a pretty good job of convincing surgeons that it's what they need to do, but it really doesn't seem to affect the patient outcomes. From a pulmonary standpoint, obviously there's a direct involvement of the respiratory status and anesthesia. The biggest thing we tend to encounter is that a lot of our medications will cause respiratory depression. So if it's somebody that's under general anesthesia, that's not really a big deal. But if it's somebody that's receiving a sedation case or like a MAC case, it may be a little bit bigger issue. When we were in the ICU, we didn't really have to think about it so much because most of the patients we were giving pain medications to were ventilated. In the operating room, we see other things happen. We may do heavy sedations. We may have what we call room air generals, which is essentially a patient that is receiving doses of medications that would be commonly associated with general anesthesia, so say like a propofol infusion, but they may not actually have an endotracheal tube in place or an LMA. So we have to be very cautious with those patients because something as little as 25 to 50 mics of fentanyl may be enough to tip them over the edge. The other thing we see is that we may not be as vigilant as we should be. So those patients that are getting sedation or somebody that's maybe coming in for a colonoscopy, something like that, that we're trying to give them a large bolus of sedation to be able to either, choke a scope down or be comfortable during colonoscopy. They tend to have little periods of apnea or periapnea. And during that time, it's very incumbent upon us to, one, have a backup plan if they don't stop or come back to breathing. And two, the other thing we see is a lot of times because of that loss of muscle tone with the anesthetic agents, they will actually obstruct their airway. So you may be able to just reach over and open that chin up and that solves the problem. Or it may result in having to actually ventilate the patient with a bag valve mask or ambu bag. So common things that we encounter as far as disease processes from a pulmonary standpoint, as I talked about the other day, URIs are probably one of the most common things we think about for pediatric patients, but we may see URIs in adult patients as well. Especially as we're starting to see more of these strange respiratory viruses that are coming and going. We're encountering that pretty frequently. We're always aware of our asthmatics and COPD patients, but we may not know the exact extent of their disease because it's been stable for some time. We're starting to see less chronic smokers, but it is definitely still a consideration. And when you guys get to the operating room, you will see how hard smokers make anesthesia, especially in terms of like a smooth intubation or a smooth emergence. They're very prone to reactive conditions, whether it's just a matter of they cough once or twice and next thing you know, they've got some phlegm on their vocal cords and now they want a laryngospasm. You may have a hard time oxygenating them because of their lungs, or it could just be an issue of they smoke heavily and when they wake up, they just cough and cough and cough and cough. You will also encounter lots of patients with undiagnosed sleep apnea or apnoea, in my typo there. I oftentimes say that we should do a propofol apnea test. We can save people the money of having to go do a sleep study because you give somebody a little bit of propofol and it becomes very clear if they're going to obstruct or not. They don't need to go pay for the $100,000 sleep apnea test. Not that it's $100,000, but it's expensive. And then finally, patients that are scheduled for lung resection. And one thing you have to consider with these patients is they may be those smokers, but we also encounter a fair number of young patients that are coming in with metastasis that may require lung resection as well. So very different pathophysiologies as you go from one to another. From an endocrine standpoint, the most common disorder we encounter is diabetes. A large percentage of the population is diabetic or pre-diabetic or has metabolic syndrome, as we've started to call prediabetes. We also see a fair number of patients with thyroid disorders, which one of the things we have to take into account with our thyroid patients is, as we discussed with airway stuff the other day, it may not just be a matter of their hormonal levels. You may have physical difficulty as well because of masses or changes in body habitus. So that's definitely something you have to think about too. We'll talk about it a little bit more when we get to that point, but patients with hypothalamic, pituitary, and adrenal disorders, they have a very strange feedback system there. And a lot of times either their medications will interact or our medications will interact with their disease process. And then finally, as I talked about the other day, that always concerning pheochromocytoma. From a kidney standpoint, nothing under anesthesia is going to make your kidneys work better. One of the biggest things we have to worry about is that use of most of our anesthetic agents will decrease renal blood flow, which results in a decrease in GFR. So even a short period of hypotension may be enough to tip somebody into acute renal failure if their kidney function is not real great to start off with, or they're, already kind of auto-regulated to a higher blood pressure. So that's something we need to be very mindful of. If you go through and look at a patient's renal function labs beforehand and afterwards, you'll see that even without those periods of hypotension, just due to surgical stress, a lot of times their GFR will drop off. Other things that come into play, a lot of the things we do to people are not good for their kidneys. So a lot of our medications, a lot of the contrast we use is bad. It's a very fine balance between getting what you need accomplished with contrast and not tanking somebody's kidneys. A lot of facilities have now gone to using a kind of a kidney protective protocol for patients that are high risk for renal injury if they're going to require large amounts of contrast. And a lot of times when we think about contrast, we think about CT scans, but on our side, it may be contrast that's used intraoperatively, especially for vascular studies. So that contrast adds up pretty quickly. From a liver standpoint, one of the biggest things we have to think about is that if their liver doesn't function quite properly, they may not metabolize a lot of the medications we give. The biggest thing we see is that a lot of our sedatives and opioids may have kind of an exaggerated effect because they stick around longer. So something for us to pay attention. And a lot of times what we'll do is start off with lower doses for these patients and then increase as the patient kind of demonstrates need. But it's an interesting process because a lot of times the reason they have liver disease is because of polysubstance abuse. So you may wind up thinking you need to give less, and then you actually give a lot more just by virtue of the fact that the patient has a pretty extensive history of substance abuse. Somebody got their mic. I think it's for the echoes. All right. Other things we encounter. We talked a little bit about liver being associated with alcohol abuse, but we will also encounter patients with hepatitis. We think about hepatitis being associated with bloodborne infections, but we're seeing more and more that a lot of the fecal oral contamination versions of hepatitis are flaring through improperly prepared food in restaurants. So we try not to be judgmental and assume that somebody has hepatitis because of a poor life choice. Other than, I don't know, if eating oysters is a poor life choice, you may have to lump that in there. From a hematologic standpoint, some of these things are fairly straightforward. Some of them get very complicated quickly. So a lot of times with the complicated disorders, we're going to kind of refer out or default to the patient's hematologist. But at the same time, we need to be familiar with the disease process to know that that's what needs to occur in that situation. Anemia is something fairly easy to identify and treat on the surface, but the causes of anemia may be a lot more difficult than we really understand. So, obviously we usually think of anemia from a blood loss standpoint. It can also occur due to iron deficiency. You may see patients with sickle cell disease. Like we talked about the other day, there tend to be regional clumps of some of these. So for instance, when I was in Shreveport, we had an extremely high populations of patients with sickle cell disease, and they all present with their own anesthetic complications or potential complications. So that's definitely something you have to consider for those patients. What am I going to bring their hemoglobin to? How can I adequately treat them beforehand? Sometimes patients with sickle cell disease will have to come into the hospital the night before to be transfused or receive volume resuscitation, so they're ready to go to the operating room the next day, which is a little bit different than a lot of our other patients. Other things you may encounter, especially in pregnant women, we tend to discover clotting disorders when they become pregnant. Kind of the usual pattern there is you'll have somebody that maybe has a miscarriage or two, and then they go in for testing, And at that time, one of the most common things that they'll discover is this G6 PD deficiency, which results in kind of strange clotting behaviors that happen. And a lot of times, like I said, that's how they'll wind up losing the baby. So you may see that sometimes they wind up having anemia. Sometimes they wind up with strange breakdown or strange clotting, like I said. So there's a lot of things that you kind of have to think about ahead of time for some of these patients. You will also run into weird coagulopathies. Think about stuff that may run in royal families. There's all sorts of things you have to consider from that standpoint that may need to be evaluated at first. It may not be picked up on like going to the primary care doctor. You may just be talking to the patient and, they talk about they've got strange bruising. Like, oh, that's kind of weird. It's not normal that your gums bleed every time you brush your teeth. Does your liver work okay? So like I said the other day, if you draw a lab test, you're responsible for the outcome of it. So maybe you check a CBC, you check a coags, and all of a sudden you figure out their INR is very high. Now you've got to dig a little bit further into it and get them over to somebody that really can evaluate that sort of thing. From a neurologic standpoint, one of the biggest things we encounter is cerebrovascular disease. If you think about a patient that is high risk for cardiac events, they're probably also high risk for neuro events. Vascular obstruction that occurs one place is fairly common to occur other places. So if you've got somebody with peripheral artery disease, they may have cerebral vascular disease, they may have cardiovascular disease. So generally after they've checked one of those boxes, I assume they're high risk for all of those. So with that in mind, you may have to keep their blood pressure a little bit higher. Seizures, as we talked about the other day, important things to think about: when was their last seizure? What medications are they taking for it? How do their seizures present? Because all those things can kind of alter your anesthetic plan. MS, we're starting to see a little bit more activity as far as the treatment of it, but it's not something that we've really dealt with a whole lot in the operating room till now. Sometimes these patients will come in for surgical procedures as a result of their disease, but more often than not, it's going to be something totally unrelated. But problems we run into from an anesthesia standpoint in patients with MS, use of muscular blocking agents may be problematic. They may have lost some muscle tone. So it may be somebody that you don't want to heavily sedate to have them a little bit more awake so they're able to maintain their airway reflexes. Going back to cerebrovascular stuff, we may see patients present with aneurysms and AV malformation. Historically, these presented as urgent cranies, but we're starting to see now more and more that they're diagnosed early on through a lot of times incidental findings for something else. And they wind up getting a CT done, and lo and behold, here's this AVM. And then we may be able to take them electively a lot of times to the endovascular lab and go through and treat it there as opposed to a large surgical case. The endovascular approach results in a lot better outcomes for the patients. Parkinson's disease, again, something we've got to worry about as far as motor weakness, but the bigger thing we run into there is that there's a lot of competition between medications that patients take for Parkinson's and what we may use for anesthesia. And that kind of goes for these last three here, the neuromuscular junction disorders, as well as muscular dystrophy and myopathy. From a musculoskeletal standpoint, things we worry about for RA, patients tend to be hard to position. They may be on steroid supplements. We may run into issues with positioning them because of that. They may not have the same stability of joints that we encounter in a lot of our patients. So that's something you have to think about, as well as, like I said, the medications they've taken. Historically, they would be on steroids. Now we're not seeing that quite as much as we used to. But they tend to be on more biologic agents now, which may interact in a different manner with their anesthetics. Patients with unstable necks or spinal columns are problematic for positioning as well as airway instrumentation. That may be the reason they're there to see us, is to have this corrected. but we need to be very cautious about their positioning. If they can't do it while they're awake, we probably don't want to do it to them while they're asleep. Lupus tends to have kind of wide-ranging complications throughout the body. One of the biggest things we think about is the impact on the kidneys. So it's fairly common to see patients with systemic lupus that will develop chronic renal insufficiency. So we need to make sure we pay attention to their vascular status there. Patients with Raynaud phenomenon, a lot of times we will run into issues from a monitoring standpoint. You put a pulse ox on a finger and it doesn't work. You may have to move it to ear, cheek, something like that to find something that's a little bit better perfused. It's also a comfort issue. A lot of times the operating rooms are less than warm, and these patients tend to always be cold. So if you take somebody that's cold into a cold environment, it may take twice the effort to get them warm. So consider pre-warming for those patients, as well as kind of paying attention to what you're doing intraoperatively. There's some kind of miscellaneous conditions that don't necessarily fit in there, but things that will cause us problems from an anesthetic standpoint. We talked a little bit about obese patients with positioning. That can be difficult. How they metabolize medications may be different, especially if you use something that's widely distributed throughout the body. If there's a lot more body, it may take longer for that medication to come off. A good example of that is patients that are getting propofol infusions. It may take quite a while for them to wake up just because they have more availability. Patients that have had organs transplanted, we need to pay attention to how well the new organs are functioning. See, is it stable? Are they on medications that may cause some sort of immunosuppression? Those can be problematic for us. The organs themselves may not respond quite as normally as the original organ. One of the biggest ones we think about is patients that have had cardiac transplants may not respond to atropine because the vagus nerve has been severed. So if you have somebody that's had a cardiac transplant that's bradycardic, you may have to consider going straight to something like epinephrine as opposed to using atropine. Patients with allergies, and this is one that tends to kind of go off the rails in the hospital. Back in the day when you really had to talk to people and document things, I think we were a little bit more thorough about our allergies. Now that we're in Epic, I think everybody gets kind of click happy and everything becomes an allergy. So things you have to think about for these patients: what is truly an allergy? Because patients think of anything they don't like or anything that wasn't normal as being an allergy. So one of the common ones we see is patients say they're allergic to lidocaine. And you start asking them what happened or kind of get the details from them. And the story you get is that they were at the dentist office and the dentist injected them with lidocaine and their heart rate went up, or they had chest pain, or they started to feel dizzy or lightheaded. So to them, that was an allergy. What do you guys think actually happened there? A lot of times it was epinephrine mixed in with the lidocaine that caused all those things. But the patient didn't understand that. From an educational standpoint, nobody stopped to say, hey, this is kind of a normal behavior because of the medication that was in here. So they call lidocaine an allergy from there on out. When you start looking at surgery and anesthesia, patients that are allergic to lidocaine may be a little bit more difficult. And with that being said, they're not allergic to the epinephrine either. That's exactly what the medication was supposed to do, but nobody took a second to explain that to the patient. Another common one we see is...
Sorry, question. This happened to me at the dentist. Is it called xylocaine?
Yeah, there's a variety of different names. Depending on the specific trade name, you may see it listed as xylocaine. You may see it listed as lidocaine. There's a wide variety of kind of trade names for it. But yeah, xylocaine's a common one.
Yeah, I literally was triggered when you said that. That's so funny.
But it happens, but a lot of times, and it's not, anesthesia doesn't do a good job with it sometimes. Dentists don't do a good job with it. We don't explain to patients what medications do. So when it happens,
they just said lidocaine, and they've never had any kind of interaction. And then after that, they're like, oh, well, maybe you are allergic, but
exactly. But yeah. So when you think about an allergic reaction, that's not a normal allergic reaction, but that's what you're seeing is the additive to it is causing the problem. Likewise, when we see people that are truly allergic to local anesthetics, it's not the local anesthetic they're allergic to, it's usually the preservative in it. But again, things we don't tell our patients because we just, assume everybody knows. Something else you'll see that's a fairly common allergy is penicillin. And a lot of times when you actually start talking to people, they don't know why they're allergic to penicillin. Mom or dad said they were allergic to penicillin, and it's almost like antibiotic urban myth. It gets passed down from generation to generation to generation. And most of these people truly aren't allergic to penicillin. The reason that's concerning to us is because one of the most common antibiotics we use in the operating room is cefazolin. And there's a very, very, very small percentage of patients that have cross-reactivity between penicillin and cefazolin. So that's concerning. But with time and testing, we figured out that's not really the big issue that we thought it was. But, with EMRs, a lot of times those medications pop up as allergies, even if they're not true allergies. Other things you'll see happen, patients will get benzos or sedatives and it makes them sleepy. Same thing, not an allergic reaction, but you will even see that it's documented, got 5 milligrams of Ativan, was sleepy. Okay, most of us would probably be sleepy with 5 milligrams of Ativan. That's not an allergic reaction, right? So anytime you have a patient that presents with an allergy, stop and ask the questions about what actually happens with their allergies. Other things we'll see, patients with substance abuse tend to be problematic for us. The big ones we really have to worry about are cocaine and methamphetamines. Marijuana is not such a big deal. From a legal standpoint, it may be an illicit substance in most states, and from a federal standpoint, it's illegal. But from an anesthesia standpoint, we don't see that many complications. What we will see is that just like somebody that smokes anything else, they tend to have pulmonary complications, right? So they cough. Sometimes they will have a condition called hyperemesis, resulting from their marijuana use, especially if it's in large amounts, which is kind of interesting because you'll encounter other people that are actually using marijuana to treat nausea and vomiting. So it's kind of interesting to see how some of those medications interact. The other thing we're starting to see more and more of is patients using substances that may not technically be illegal, but definitely have interactions with anesthesia. CBD is very closely related to marijuana. And then the kind of more concerning one that we're seeing from time to time now is called kratom. And it's a stimulant. So you start thinking about the drugs we worry about, cocaine, methamphetamines, kratom kind of falls into that combination as well. And what places will do to kind of keep these legal is they will go down to the cellular level and just alter the chemical formula by one little bit. So from a legal standpoint, they have to write a new law to account for this. So that's how you see these things that are, seem like they might not be illegal or not be legal, but they are, because it takes several years for laws to catch up with things. I don't really care from one way or another. My big concern is what is it going to do to the patients? And I tend to have a very frank discussion with them that I don't care what they've done. I just need to know from an anesthesia standpoint because it would definitely impact things. So that's something you have to think about when you have patients with substance abuse. The other part is that patients oftentimes are not real honest with what they have or haven't done, especially if it is illegal or they're embarrassed about it. Nobody wants to admit they drink a case of beer every day before breakfast, but that may be what some of our patients do. So you kind of have to take some of that with a grain of salt. And you guys have been nurses for a little while. You've kind of developed that sixth sense about what's going on. So that's definitely something to consider in those patients. There are also some specific groups of patients that can be challenging for us. So when we start assessing pediatric patients, oftentimes we have to not only assess the patient, but their family member that's there. Most kids don't provide you with a real great history, so you may have to talk to mom or dad. With that being said, mom or dad may be a great resource, especially if you have special needs children. A lot of times they're kind of high-tech kids. They may have a lot of gadgets and devices that you don't have any experience with. Mom or dad may be your best resource because it's something they work with and deal with every day. They may not know our job, but they take care of their child every day, and they obviously have a vested interest in a good outcome. So that's something that may be beneficial for you, is to talk to them to see how things work or how things don't work. Those parents are oftentimes a little bit overprotective, especially in the healthcare community. And it's because over time they've learned they have to be. People may not understand what's going on, and nobody wants to have the parent tell you what to do. But sometimes we don't know, and they may be your best resource. So again, having a frank discussion with them tends to be the easiest thing for me to do. Other problems you run into with pediatric patients, they may not have been exposed to anesthesia before. So there is a little bit of increased risk of having a primary MH event or a pseudocolonesterase event. But talk to the parents, talk to anybody that can provide sort of history for you, and determine if there's any familial history of anesthesia problems. Pregnant patients can be difficult by virtue of the fact that you're taking care of 2 patients to start off with. So that's obviously a little bit more challenging for us. You have to assess not only mom, but also the fetus as well. And then the other thing you see is that a lot of times they've had kind of rapid changes in their body. So that can be something else to be considering. Yes, Alex?
How often are you doing anesthesia for pregnant women? Like, what's the most common procedure that they would go in for during pregnancy?
Outside of C-section, the most common thing you see them for is either appendectomy or cholecystectomy. A lot of times you will see that the gallbladder becomes problematic during pregnancy. So, sometimes it's somebody that had a little touch of cholecystitis before, and then they got pregnant and it worsens. Sometimes that's their initial presentation. If you look at the books, appy is the most common. My personal anecdotal experience would be that it's actually a cholecystectomy. You will see patients having their appendix out, but personally, it's been gallbladders. And what you have to think about, and you guys will get into this in great detail down the line, is really how far along are they in their pregnancy. So first trimester, we tend to worry about medications that are teratogenic. After the baby becomes viable, it's really kind of the defining moment for me, as far as monitoring, workup, that sort of thing. If we can put off the surgery till after the baby's delivered, that's probably the best outcome for everybody. But sometimes that's not possible. From a surgical standpoint, I think a lot of times they kind of push things and do cases that maybe didn't necessarily have to be done, because they've done 9 million pregnant women with no bad outcomes. And then they have one and they're like, oh my gosh, this is high risk. Why are we doing this? And we tend to kind of fall into the same thing. I've taken care of 9 million pregnant lap choles, and then I have one that has a problem, and it's like, oh, that's something you got to consider. We forget about how cavalier we become sometimes. So, like I said, the defining moment for me is the baby viable or not? Because if baby becomes viable, it transitions to got to do continuous fetal monitoring. A lot of times we will have a C-section set up in the operating room already in case there's prolonged decels or any sort of fetal distress. You usually have to keep a L&D nurse in there monitoring the patient. And then you may also have to have, make sure you've got an OB-GYN in-house to do a section if it comes to that point. So it becomes a lot more complicated. Otherwise, usually second trimester, we're just going to do pre and post case fetal heart rate monitoring. So you can see how that's a pretty big difference there. But does that kind of answer your question?
Yes, thank you.
The other thing you will see, and it's fortunately not very common, but pregnant women do not do well with insults. And I don't mean like bad words. I mean like trauma or hypotension. So you will see that a lot of times pregnant women that are involved in, and it doesn't have to be trauma. It could also be, pneumonia, COVID, swine flu, any of those sorts of things. Pregnant women tend to not do very well with it. And one of the first things that happens is they will wind up miscarrying. So, it's kind of a sad outcome all around because, whatever happened, flu, car accident happens, but then they lose their baby as well. But don't be surprised if you're taking care of a pregnant woman and they do miscarry. You can do everything right, and just by virtue of that stress, a lot of times it happens. And it's devastating for them. their family, especially if they're further along. But it's hard for you too, especially if, like, I said the other day, you got to follow up on your patients. When you follow up on somebody and you see something like that happens, it's hard for you. But don't be surprised. And then the final thing with that is a lot of times the leading cause of maternal death is fetal death and vice versa. So if you see one that expires, it's kind of common the other does. There are some cases where they're able to do a antemortem or perimortem C-section and save the baby, and mom may not make it. But that's not a very common process. You'll see a lot of times that shows up in the newspaper because it is that rare. Patients that are breastfeeding, we've kind of made leaps and bounds as far as how we handle breastfeeding patients. For a long time, we were very focused on our side of things. Mom couldn't breastfeed if she'd had general anesthesia, or mom couldn't breastfeed because she had pain medicine, because we were very worried about what would be transmitted to the baby. What we figured out is a lot of that stuff doesn't carry over nearly as much as we thought it would. The other side of that is, say, for instance, you perform a spinal or an epidural and you put a little bit of fentanyl or morphine or something like that in the baby, or not in the baby, in the mom. It's very low dose, but people get in their head that mom got opioids. And if the baby has any sort of respiratory depression, a lot of times that's the first thing they go to blame. So you'll see that some places don't use opioids in their spinals or epidurals at all. Even though it's been demonstrated it doesn't matter, kind of ignorance carries along. So, they're like, don't give mom this, don't give mom that. And it doesn't make a difference to the patient, or for the procedure. But what you will see is afterwards, those people tend to have a lot more pain, which makes sense. There's a reason we're putting those medications in there. It's not just because it's part of our cocktail. So to kind of compensate for that, sometimes what we will do is do a TAP or a QL block in lieu of giving them intrathecal opioids that may help out with that pain. And then it kind of removes the concern from what happens as far as breastfeeding. But it is something you have to think about with a lot of your medications, that there may be a potential for transmission. But more often than not, where we see it transmitted is the illicit substance use by a mom to a baby. Elderly patients can be problematic, just like young patients can. We kind of have two groups of elderly. Most of us start calling people elderly when they hit 65, but then you also have like a super elderly or like a late elderly when they get to be above 80. And the good news is, if they've lived that long, it takes a lot to kind of kill them off. And I say that not to be, rough, but just be honest. You will see that a lot of patients will survive in spite of what we do. People that have, are in their 80s and have a history of IV drug abuse are probably pretty tough. People that are in their 40s may not be nearly as tough. So, if you've got somebody that's lived that long, they've probably gone through quite a lot, and they're a little bit tougher than some of the younger patients you may encounter. The downside is, over time, you tend to pick up more comorbidities, and those kind of play into our anesthetic management of things. All right, we're going to transition into some of the kind of administrative stuff we have to think about. Do you guys have any questions about that? I know that was kind of a really broad overview of stuff. And like I said, over the semester, we'll go into things in a lot more detail, but just kind of touching on stuff there. All right, so we're going to talk a little bit about consent and decision making. Since anesthesia is a procedure, and among that there are other procedures as well, whether it's central lines, arterial lines, any of those sorts of things, we have to have our patient's permission to do those in most cases. I just included the case notes in here. Like I said, as far as like the PowerPoint notes, it's just a little bit of back history on where informed consent came from. And this was originally came out of a case in California where patient had an aortogram done and wound up being paralyzed in his lower extremities, which isn't something you think about happening. Somebody goes in to have an angiogram done, you don't anticipate that they're going to wind up paralyzed. So there are always risks that you have to think about for any procedure. And some of us do a very good job of explaining these risks to patients. Other times we give them a piece of paper and ask them to sign it. Generally, what I will do is discuss everything with the patient. And like we've talked about during this preoperative process, I usually have my anesthetic plan formulated, but sometimes there are patient factors that may affect things. Sometimes what the patient wants may be okay, but not our preferred method. Sometimes it may not be a realistic expectation. So we have to have a discussion with them about that as well. I understand what you want, but that's not a way that we can perform the surgery. The other thing you have to think about is it a way you can perform the surgery? I've had a couple patients in my career that were high risk but needed, say for instance, a lap chole. And we could have done it open, but open cases tend not to heal as well. In a normal situation, we will do a lap chole under general anesthesia. These patients were not amenable to general anesthesia. So what we did was infiltrate the port sites, provided a little bit of sedation, kept the patient comfortable, and actually did their lap choles under a MAC or a sedation anesthesia. Not ideal, but it worked out. It was probably the best option for those patients. So just because it's not something we do commonly doesn't mean it can't be done. So think about that. So when we're talking to patients, we need to disclose the risk associated with procedures. The most common risk from an anesthesia standpoint tend to be cosmetic, teeth getting knocked out, dental trauma, lips may be lacerated or abraded. So those are the common risks, but then we also need to think about kind of the high risk stuff. As part of this breathing tube going in, you may experience a period of decreased oxygenation. And then kind of the capstone to all these things is it may result in coma or death. So you have to think about that. So two approaches when you're consenting somebody. Think about common complications and think about high risk complications. So that's general anesthesia. If you're talking about doing a spinal or an epidural, common complications, you may have some tenderness in your lower back. There is a slight risk of infection. You may wind up with a post-dural puncture headache. High risk complications, epidural hematoma, paraplegia. You may have a entrainment of air. You may wind up with meningitis, stuff like that. Something as simple as a central line or an arterial line. You have a risk of pneumothorax. You have a risk of vascular injury, infection, air embolus or catheter embolus, stuff like that. So those are the things you really have to go over with patients. Like I said, a lot of times we kind of rush through that part of the process and hand them a form that they don't bother to read that has all this information on there, but it's kind of a big deal. So I think a lot of times if we explain to patients that these are the complications and risk associated with their anesthetic, they understand things a little bit better. And that way, if something bad does happen, not only did you do the right thing by disclosing it, but they're more likely to remember it or at least have understanding of it. Other things that come into play, who is able to consent for the patient if they can't consent for themselves. It varies from one facility to another and one state to another. Some places, the chaplain service serves as kind of a third party and will consent for patients. Other places, two providers can consent if you're not able to find family. If it's an elective case, a lot of times we wind up having to put it off and play phone tag, trying to find somebody that can consent for the patient. And by the time you get to like the third cousin twice removed, it may meet the legal definition of consent, but I'm not sure how helpful it is. So that's something you have to consider for stuff. Any questions about consent? All right, we touched on DNR orders the other day. A lot of times facilities will have policies that address what happens with the DNR order during the perioperative period. Most of the times what happens is it gets suspended for that surgical time as well as about the first 12 to 24 hours afterwards. Sometimes when the patient leaves the PACU, it goes back into effect. But it's something you need to discuss with the patient. Make sure they understand that this is a little bit different than their normal DNR order because medications we use may cause things that would violate your DNR order. the active general anesthesia may violate your DNR order. So make sure the patient understands that, and also understand that you are going to suspend that DNR order during that perioperative period. Sometimes when they find that out, it may be enough that they don't want to have whatever the case done. Other times they're okay with it. And again, have this discussion with family if they're present as well. When we start talking specifically about our older patients, oops, sorry. Go ahead, Jennifer.
I was wondering if there's been times where you've had to leave the DNR order like in place and still perform, because I know in our last semester we had like a paper to write about that. So I was just curious if you've ever experienced where you had to leave the order on.
Yes, but part of it just depends on exactly what the patient wants and whether they're able to consent. Usually it's for cases that I don't think it's going to matter. Not that that's really a good answer, because you could wind up having to do a general anesthetic at any time, but sometimes for sedations and stuff like that, we won't worry about it. Sometimes we may be doing that sedation or spinal or nerve block to kind of skirt the issue of the DNR order. But for the most part, I have a pretty frank discussion with patients that we're going to have to reverse their DNR order during that perioperative period. And like I said, the biggest reason for that is just, routine things we do would violate that DNR order, at least the letter of the law. Some people may not consider giving a bolus of ephedrine or neosynephrine as a vasoactive medication. It's not like you're putting them on a leaf-fed drip and sending them to the unit. But you may have to do things like that to counteract the anesthetic effects. So there have been times, but usually it's times that I didn't think it would be a factor.
Gotcha. Thank you.
Yeah. Is there another hand?
Yes, me. I had a question. Going back to the consent, I meant to ask, have you had a situation where you have a patient as a warden of the state in this emergent situation where you have to do like an emergency surgery that's life-threatening? How do you proceed with that, especially if they have an active representative and you can't get in contact with them?
So if it's an emergent situation, generally we're going to do whatever we feel like would be in the patient's best interest. So if the patient is unconscious and unable to consent, whether they're a ward of the state or not, we're going to proceed with the emergency, surgery, whatever it happens to be, or intubation or central line or whatever you have. Where it tends to be difficult is patients that are wards of the state for stuff that's not emergent, because now you've got to go through and figuring out who can consent for that patient varies from one place to another. For instance, some places you have to get a judge to say it's okay. And this is kind of a stretch there, but like if you're talking about somebody that's maybe like in child custody or in a group home or something like that, sometimes you have to get the family court judge to say it's okay for them to have surgery. Sometimes if it's a prisoner, you have to get the warden to consent. Sometimes the warden won't consent. It's got to go to another judge. Sometimes there's a facility representative like the nurse or the physician at the prison may be the one that can say it's okay. But it kind of varies a little bit from one place to another. For instance, at JPS, we see state inmates, we see county inmates, and we also see federal inmates, and all of those processes are a little bit different. The nice thing is for non-emergency surgery, if you have a good social work department, a lot of times they've kind of figured that stuff out beforehand. Because just like we talked about the other day, somebody shows up for surgery and now we have 5 hours of phone tag trying to figure out who can consent for that patient. It's frustrating for everybody that's involved. But a lot of times with our pre-op process and with our social workers, if we're not able to do it, they can kind of work through those hurdles before they get to the operating room. And then, like I said, if it's emergent, you kind of have to do what you think would be in the patient's best wishes. And you run into that from that perspective with a lot of things. Patient can't consent, or consent would be deemed to be under duress. So say, for instance, somebody, you feel like is dying and you have the ability to do the anesthesia or the surgery that would save their life. Trying to consent them when they're in that type of situation would never hold up in court. Because they've probably already gotten some sort of medication. So you just have to do what you feel like is in the patient's best interest. And outside of that, get to providers. Say, for instance, you've got a psychiatric patient that's done something to try and end their life. They obviously have no interest at that time of doing anything to save their life. So you may have to intervene and do what you think would be best for the patient, in spite of the fact that's not what they want. Sometimes it comes down to a legal status determination. So depending on what state you're at, it may be a detention order, it may be an emergency custody order, it may be some places called the Baker Act. It really just depends on where you go, what it's called. But those patients may not be able to make determinations for their own needs at that point. But again, it just depends on where you're at and kind of what's going on. But those are always kind of challenging and frustrating for everybody. Again, if you can kind of catch those on the front end, it makes your life a little bit easier.
Thank you.
Yeah, no problem. All right, so moving on, talking a little bit about elderly and frail patients. And part of this we've touched on, part of it is a little bit more in depth for this patient population. So things you have to think about for these patients, especially as they get a little bit older and a little bit more frail, think about modifiable risk factors, things you can really do to optimize their surgical outcomes. And then also something that we oftentimes forget about on the anesthesia side, what happens after surgery? There's things that we do that can make a big difference for patients. Part of it may be medications we give them. If we give them a lot of long-acting medications, you may result in some cognitive decline. You may see that they have to stay in the hospital for some time afterwards because they've got delirium. We may give them medications that are long-acting that result in, prolonged hypotension. Or maybe something as simple as giving a large dose of steroids results in their blood pressure or blood sugar being out of control. And now they've got to come into the hospital on insulin drip to try and get that regulated. So think about things like that. And it's not tied just to elderly patients. When I say frail, I tend to think of like brittle patients. So brittle diabetics, people with medical conditions that are very tenuous at best. We really have to think about what we're doing for those patients and the impact of our interventions. Other things to think about that we kind of skip over, patients' daily activities. I may be able to give somebody a nerve block, but if they can't walk afterwards, what happens when they get home? If it's an upper extremity, I may just say, hey, I'm going to need to put your arm in a sling. But if it's a lower extremity, what are they going to do? They can't get out of the wheelchair to get in the car. When they get home, there's nobody to help them into their house. Their legs numb for 24 hours. People that have, a history of falls or maybe live alone. We usually do a good job of making sure somebody stays with them for like the first 24 hours or so. But that person that's staying with them may not be able to help either. If you have an elderly couple, for instance, if one falls, the other one probably can't help them up. So you want to make sure that even though it's not really what we consider our resources, that our anesthetic plan doesn't result in complications for them. And then, like I said, cognitive impairment is something we're really just starting to understand. And part of it is because we don't entirely understand how a lot of our medications and techniques work. But we're seeing if we can avoid things like general anesthesia for some of these patients, or long-acting medications, or benzos, or even some of our PO pre-meds. They can really result in some impairment for the patients that can be kind of a short-term complication that may have long-term risk with it. Other things to think about, patients' nutritional status. Sometimes we catch this during the pre-op process that, they're not eating well, they don't have food, they have some sort of food insecurity. Other times we just noticed it on the back end. Their nutritional status was poor, and sure, they did great from a surgical standpoint, but now they've got infections or, their wounds aren't healing. All those things result in them staying in the hospital longer. So if we can kind of catch that beforehand, we may be able to set them up. Again, social work plays a big role in a lot of these things, following up with those patients to make sure that they're getting what they need afterwards. It's not just a matter of home health. It may be, Meals on Wheels comes by to make sure they're eating. Stuff like that. One of the nice things that came out of COVID is I think we increased our home health capabilities a lot for basic needs. Before it was a lot of, you needed IV antibiotics and stuff like that. Now it's just somebody getting by to make sure your medications are doing what they're supposed to do. So I think that was a good thing to come out of it. Another thing we see in a lot of our elderly patients that gets missed is a lot of the mental health issues. I think one of the biggest catches to that is a lot of the times they have kind of social isolation as they get a little bit older. So as a result of that, they've lost their social network. People don't catch things. They may not have interactions like they did previously. So obviously, if we put any of us in a kind of a situation where we didn't have our daily interactions, that would be kind of depressing. And a lot of times it leads to substance abuse. I think one of the populations that gets missed a lot of times for suicide is actually the elderly, for this reason. So we're going to transition from that to a little bit of actually calculating surgical risk. So when we look at patients, we break risk up into a couple of different categories. So you have surgical risk, which is the risk associated with the procedure itself. So we have high-risk procedures, which are pretty straightforward. Major vascular surgery, major aortic surgery, PVD, stuff like that. Intermediate risk, which is kind of some of your lighter cardiac stuff like carotids, head and neck surgery, surgery inside the chest, non-cardiac. So like lung surgeries, belly surgeries, those are kind of intermediate risk. And then we have low risk procedures, which is everything else. Where this really comes into play, a lot of times you will have somebody that goes to a primary care doctor for risk stratification. What they're going to do is look at the case they're having done and then look at the patient's risk. So they may say that the patient is low risk because maybe they have a low cardiac risk index for a high risk procedure, or they may say they're high risk for a high risk procedure. And this really just helps us stratify how significant this is. So if you have somebody that's higher risk for a low risk procedure, maybe they don't need to have that low risk procedure. On the other hand, if it's a high risk procedure, there's not a lot of those that can be put off. But you may be able to, not necessarily from our standpoint, but they may be able to have it done by another technique. A good example of this is a lot of our cardiac and vascular stuff was always done as an open procedure. Over about the last 10 years, we've started to see that we may be able to do this as an endovascular procedure. So you can take that high risk case and take it down a little bit. So for instance, valve replacements or carotid endarterectomies, now we can do those from an endovascular standpoint, which helps decrease the risk for the patient. So that's surgical risk. This is cardiac risk. And this is a pretty common tool. I would be familiar with it. So what you do is you go through and you look at each of these components. So again, you've got to know what type of surgery it is, and then know your patient's history. Do they have any sort of ischemic disease? Excuse me. CHF, CVD, diabetes, all those things, you can see how it would increase your risk. And then finally looking at their kidney function. So if you have anybody that's over kind of 3 points there, they're fairly elevated risk for a cardiac event during the procedure. So why does that matter to us? This may be somebody that you decide needs an extra monitoring device during the case. So maybe you decide to put in an arterial line, or maybe this is somebody you want to have a TE done, or maybe this is somebody that needs a little bit more optimization before they go to the operating room. So you'll see those two things fairly frequently, whether it's on an exam, or you may also just see it as a reference as part of the preoperative clearance process. This is that functional capacity I touched on the other day. And it's really just an assessment overall of how fit a patient is. So you can see here examples of different METs. So one is what we're all doing right now. Some of us might even be two while we're sitting there. So there's not a whole lot of activity involved in one MET. Two METs, walking around your house, doing kind of daily activities. 3 METs is walking a block or two on level ground. And generally, we start thinking about patients being okay for surgery when they get above 3 METs or above 4 METs. So, 4 METs is raking leaves or gardening. That's not a whole lot, but if you think about somebody that can only do very limited activities, walking around, standing upright, and moving a rake may be a lot of activity. Gardening, depending on, I guess, how you do it, can be pretty intensive. If you're crawling around on your hands and knees and digging holes, that can be a lot of effort. And then greater than 4 mets, so climbing a set of stairs, dancing, bicycling. Again, there's some degree of variation here depending on the person. Generally, what we're looking for when we start talking about metabolic activity is somebody that's greater than 4 mets. So you will commonly hear, can you walk a block or two? Or are you able to walk up and down a flight of stairs without getting short of breath, chest pain, that sort of thing? The reality is that walking a block or two on level ground is probably not really 4 mets. Other things you have to think about, how do they do it? So if you ask somebody if they can walk a block or two and they say yes, but they have to stop every 5 feet because they're short of breath, that doesn't count. This is somebody that can complete that activity without any sort of complication. And then you can see other examples here. Like I said, there's some variability, I guess, depending on how intensive you're playing tennis or swimming or golfing or any of those sorts of things. Sorry, my screen froze. Other things that come into play, the type of surgery. So some places have different definitions, but generally an emergent case is one that if it doesn't proceed immediately within the next 2 to 6 hours would result in loss of life or loss of limb. So a lot of times we think about patients having, traumatic events, amputations, gunshots, those sorts of things are emergencies. But emergencies could also be somebody that's got an ischemic embolus of the leg. And if we don't take them to the operating room, they're high risk for losing it. Or somebody that maybe has a ruptured globe. So we need to get them to the operating room to get their eye cut on. Those sorts of things can be emergent. So things we have to think about there is we try and assess the patient, but there's only so much optimization and maximization you can do in that sort of situation. You may not see the patient at all preoperatively. The 2 to 6 hours is very generous. A lot of times you see the patient as they're rolling through the door of the OR. So you may not get any sort of workup done. You may be dependent on what the patient can tell you. So for those patients, when we're preparing an anesthetic plan, a lot of times we think about the most cardiac stable and the most intensive monitoring. So most emergent cases will wind up getting a couple IVs. They may get an arterial line. They may wind up with multiple vasoactive medications just by virtue of we don't know anything about the patient. So after emergency, you have urgent. So urgent means they need to get done within the next 6 to 24 hours. So maybe a little bit more time for optimization there. And then finally, time sensitive, which really means it's something that needs to get done shortly. So this is something the surgeon sets. We don't decide how urgent a case is to be done. We just, and not that it takes any of the liability off of us, but if we don't go through the formative optimization and evaluation process, it becomes an emergent case for us. So even though it's an urgent case for the surgeon, we may say, hey, the patient needs these 2 or 3 things done to be able to be done safely. He says there's not time for that to happen. So from our perspective, it's an emergent case. So those are things you kind of have to think about there. And like I said, it certainly doesn't relieve any of the liability by making an emergency case, but there's a little bit less expectation for perfection at that point. Something else that comes into play, like we saw with COVID, cases could be done if they were emergent, if they were urgent, or time sensitive. So things you have to think about for like a time sensitive case, maybe somebody has been diagnosed with cancer and we can remove it now and stop it from spreading. But if we wait 6 weeks, 12 weeks, it may spread. So that would be a time sensitive case. I will also say in surgeon talk.
Is there a way for me to check those?
Hang on one second. In surgeon talk, you can make anything time sensitive. So, you know, I think like cancer was something that was viably time sensitive. Coming in for your breast dog was probably not time sensitive. But if you give a surgeon enough time, they can figure out a way to justify what they're doing. So sometimes we get drug into that whole process as well. All right, let's take a break for like 2 minutes and we'll come back. All right, so this is kind of an example of the flow chart for how this works as far as figuring out cardiac assessment for patients. So if you have an emergent case, obviously you're going to take the patient to the operating room now. If you have somebody that has cardiac conditions, for example, we want to postpone the surgery until we can evaluate and figure out exactly what's going on. Part of that evaluation is using these tools we looked at. So like the RCRI to figure out if they are high risk. There's some other calculators out there you can look at as well. If you do those calculations and they turn out to be low risk at that point, it's okay to proceed to surgery. If they are higher than 1%, you want to go ahead and take a look at their functional capacity. So if their functional capacity is more than 4 mets, then it's okay to proceed to surgery. If you have somebody whose functional capacity is less than 4 mets, you want to stop and look and see if what you were assessing will impact what's going to happen for them. So one of the big issues we run into is a lot of times determining the kind of functional status of patients may not be enough. So we look at doing stress tests. Some of our patients are not able to complete an exercise stress test. So they may have to have a pharmacologic stress test done. And after that, we may still not have any sort of clear answers. So they may decide to go ahead and do a cardiac cath at that point. So to determine anesthesia risk stratification, we put together our own kind of series of things. But the other thing is we kind of figured out other things that come into play. Some of these are official, some of these are unofficial, but there are definitely things I would consider. So this was one of the best explanations I found of it. So the surgical procedure comes into play. I think this is really one of the big things, this one and the skill of the anesthetist. So I think you have to take an honest look at a surgeon's skill and capability for what they're doing. Some surgeons are very honest about themselves. Others tend to overestimate their capabilities. We know everybody is not the same. not all surgeons are the same. Not all anesthesia providers are the same. Think about the capabilities of your PACU. All PACUs aren't the same. I've worked in facilities where the pre-op nurse was also the OR nurse, was also the PACU nurse. Not bagging on them at all. They were amazing nurses. But it's a little bit different when you have a nurse that specializes in taking care of somebody after anesthesia versus somebody that does everything. A lot of times what you see in PACU nurses is they are ICU nurses that wanted a better schedule, but that may not 110% be what happens. So again, think about the capabilities of your PACU. And then something else you have to think about is your capabilities. Take an honest look at what you do, what you're capable of, and what sort of experiences you've had in the past, because that definitely affects how comfortable you are with things. So this is kind of an unofficial stratification of anesthesia risk. And this is just a little bit of a flow chart that kind of goes over some of those things. From an anesthesia standpoint, things you have to think about, what's happened to you in the past. Did you have errors in judgment? Are your characteristics and your traits okay with this? Or is there anything you can do to kind of influence any of these? When you get down to the surgical standpoint, we try and do what we can to alter the patient's disease state, or at least optimize it as best as possible. From a surgical standpoint, they can experience some of the same things we can. Bad outcomes because of decision making. Patient may not get the best post-operative care. And all of these things come together to impact what happens to the patient on the back end. Are they happy with what happened? Are they totally pain-free? Do they bounce back to the hospital 24 hours later with an infection? Do they wind up with some sort of weakness? Or do they not make it out of the operating room? All these are factors that really come into play for these patients. So some of them can be adjusted, some of them can't, but they all need to be considered. So this is the ASA physical status score. And this is how we stratify patients from an anesthesia standpoint for risk. So ASA1 patients are healthy with no coexisting diseases, non-smoking, little alcohol use. An ASA2 is somebody that has some sort of disease process, but it doesn't seem to impact their function at all. So think about somebody that smokes, somebody that drinks a little bit of alcohol. Pregnancy automatically makes you a 2. Obesity less than 40 makes you a 2. Somebody with diabetes, hypertension, or lung disease will also make you a 2 if those are controlled diseases. ASA3 is somebody that has a severe systematic disease or a systemic disease. So poorly controlled diabetes or hypertension, lung disease, BMI greater than 40, liver issues, somebody that has ESRD, but they're compliant and going to dialysis. ASA4 is somebody that has a severe systemic disease that is a constant threat to life. So think about somebody that's had a recent MI, stroke, stent placement, evidence of poor valvular function, low EF, sepsis, DIC, ARDS, somebody with renal failure that's not being appropriately dialyzed. ASA5 is a patient who is not expected to survive without the operation. So think about like a ruptured AAA, trauma, head bleeds, a dead gut, that sort of thing. And then ASA6 is somebody that's brain dead who's going to have their organs donated. So the way this will work is when you see a patient's evaluation, you will have this number, so ASA or physical status 3, and then if it's an emergent case, you'll have an E afterwards. So you can have a 1E, you can have a 5 or a 6 will always be an E. But just kind of shares the overall evaluation of the patient's anesthetic risk and kind of status. So preoperative testing, and we'll talk a little bit more about this later on based on each kind of body process. But pre-op testing is really based on the case that's going to be done, your history and physical examination, and then the patient. There is not a standard pre-op testing that we order for every patient. So things for you to think about. Like I said, if we're ordering a test, we need to be responsible for the outcome of it. If the test is being done, it needs to be something that's going to change our management plan. We don't just do tests because, if I'm doing a blood test, I need to know the results of it. And that's part of the reason I said it's very important not only for us to wait on it, but also for us to have something altered by that result coming back to us. A lot of these lab tests are expensive. We don't think about that in the ICU because somebody else has made the decision. Some places do like daily labs. We know that's not a cost-efficient practice. So think about what you're actually getting out of a test that you're ordering. So these are examples of when we would use certain testing. So CBC, H&H, that sort of thing. Potential blood loss surgeries. So if you've got a patient with a history of bleeding, some sort of hematologic disorders, anticoagulation, or poor nutritional status. If you have higher risk patients that are undergoing intermediate or higher risk procedures, go ahead and consider it. And then anybody that's going under a major procedure ought to have a CBC checked. Renal function for diabetes, hypertensive patients, cardiac disease, people that are demonstrating fluid imbalances. So think about like dehydration, nausea, vomiting, diarrhea, patients that may be fluid overloaded. So again, ASA 3s or 4s for intermediate risk procedures, or pretty much anybody that's undergoing major procedures. You'll notice that it's kind of a standard thing. High-risk patients probably need a little bit more workup, which makes sense to us. Electrolytes, if you have somebody that is in some sort of condition that you think will alter your perioperative management, make sure you check the electrolytes. Other things for you to think about, and I'll hop back to the CBC. If all I really need to know is what their hemoglobin and hematocrit is, that's all I need to check. I don't need to get a full CBC on everybody. So for instance, if I had a patient that I transfused or was transfused, and I just want to see if their H&H has gone up, that's all I need to check. I don't need to get a CBC. There's a lot more expense and time involved in that process. On the other hand, if I need a platelet count, I can't get that from an H&H, so I'm going to have to add on the CBC. LFTs, if you've got somebody with existing liver issues, they're kind of a standard there. Or if you have somebody that has bleeding disorders, we want to check and see how well their liver is working. If you have somebody with known coagulopathies, go ahead and get coags done. If you have somebody that's bleeding or on anticoagulants, get coags done. Again, if you've got somebody that's going through an intermediate or high-risk procedure on anticoagulants, or they're a 3 or 4, go ahead and get coags done. If you have somebody with diabetes, particularly somebody that's diabetic that may not be very well controlled, consider getting a hemoglobin A1C. Otherwise, from our standpoint, you may not get a whole lot of benefit of it. You may be able to look back and see when they're done. Something we have to think about is how current do we need labs to be? If you've got somebody that's coming in for a routine surgical procedure, a lot of times we will take lab work that's been done in the last 3 to 6 months, but it also depends on what's happened to that patient in that time period. If you had somebody that's had a major life change or multiple medications or some sort of big medical procedure in that time period, you probably want something more frequent. If you had somebody that got a big transfusion yesterday, you probably want to see where they are in the morning of surgery. You don't want to rely on lab work from 3 to 6 months ago. If you have patients that are going to be getting hardware implanted, or somebody you think may be septic or maybe have an UTI, probably want to get a UA. A lot of times this has already been done for you, but it may be something to bring up to the surgeon if it hasn't been done. Hey, your patient hasn't had a UA done. It looks like they may have urosepsis. So a lot of times the way this situation plays out is you have somebody come in from a nursing home. Maybe they fell there, broke a hip, and now they're hypotensive on the floor. Are they hypotensive because they're bleeding, or do they have some urosepsis? Things like that to think of. Pregnancy tests are like a constant back and forth decision. Some facilities have across the board policies. Other times it comes down to the individual provider deciding whether or not they need a pregnancy test. Things that come into play, age of the patient. Some places, like I said, if you're between 12 and 65, they will insist on a pregnancy test for you. Other things to come into play: patient's last menstrual period, are they on birth control? The general recommendation is that any women of childbearing age and that are potentially or possibly pregnant get a pregnancy test done. Doesn't have to be a true formal test. A lot of times we're just using like a point of care test at the bedside. Like I said, it goes back and forth as far as does it need to be done, does it not need to be done, what's the benefit of it. And I think going back to when we talked about pregnant women earlier, you really have to think about the medications you're giving and how they would impact things. For instance, if you have somebody coming in for a colonoscopy where you intend to just give lidocaine and propofol, it probably doesn't matter if they're pregnant early on. On the other hand, if you're somebody that uses a lot of Versed or fentanyl or something like that, you may want to get a pregnancy test. But usually we try and have kind of across the board standards so everybody's consistent with stuff. Most patients with cardiac disease, we will try and make sure we have a current EKG. So current generally means within the last year or with any sort of major change. If you have somebody that's increased risk, so 3 or 4 for intermediate risk procedure, or anybody that's having a high risk procedure done, probably want to get an EKG. EKGs are not very good at telling us what's happening, other than in the case of like an ST elevation MI. It's more of what's been done, but it may indicate some sort of cardiac damage you were unaware of in that patient. Chest x-rays, for a long time, anybody coming into a hospital would get a chest x-ray done. We figured out that probably wasn't the best use of resources. So from our standpoint, if you identify any sort of pulmonary or thoracic concerns during your preoperative evaluation, you probably want to get a chest x-ray. Or anybody that's got any sort of lung findings, abnormal breath sounds, make sure you've got a current chest x-ray. I just put this up there because some people have not seen this before. This is just a quick annotation of how you can document your labs. So I don't want you guys to get to clinicals and see this and be like, well, that's a cool little drawing. I wonder what that means. This is a way you can document your lab findings. So on the left side there is your CBC, white count on the left, platelets on the right, and then H and H in the middle. Right side's coags, INR up above, and then PT and PT down below. And then the bottom is kind of your chem panel: sodium, potassium, chloride, CO2, BUN, and creatinine. So just something for you to remember in case you happen to encounter it. So we're going to talk a little bit about the different types of anesthesia. You guys will get a lot more of this, but it's just an overview of it. And sometimes these lines get a little bit blurred, especially with these two here. So general anesthesia is technically the total loss of consciousness and airway control. Most of the time it means you have a breathing tube in, whether it's an LMA or an endotracheal tube, but not every time. And really where it gets blurred is patients that are getting heavy sedation to the point of general anesthesia. They've lost consciousness and they are not able to control their airway, but they don't have a breathing tube placed. Commonly, you'll see this happen with colonoscopies, EGDs, and then sometimes for out-of-office procedures. So plastics or dental stuff that's done in office may not have a endotracheal tube in, but often get to the point of general anesthesia. IV sedation or monitored sedation, or what we call MAC, monitored anesthesia care, is truly just sedation. They're able to interact. They may be asleep, but they're able to wake up and protect their airway. Just because they're not awake doesn't mean they have general anesthesia. These patients should always have either a nasal cannula or a face mask placed. Regional anesthesia is a type of pain management that basically numbs up or anesthetizes a large part of the body using local anesthesia. So it may be done as an epidural or a spinal as a neuraxial, or you may see it done as a peripheral nerve block as well. And then local anesthetic is a one-time injection of a local anesthetic area into a small part of the body. So think about like, somebody's getting sutures, or maybe they're having a laparoscopic case done, and we've combined techniques. So we may put local anesthesia where we're putting the ports, but we've provided the patient with a general anesthetic for the procedure. So that way they don't have discomfort from the port site, but they also aren't awake during the case. Any questions on those? Like I said, you'll get into that in a little bit more depth, but it just kind of gives you a quick overview of the different types of anesthesia. Something else we have to think about, planning for postoperative pain management. We should appropriately treat all of our patients for pain. If you talk to patients, the two biggest dissatisfiers they have are pain and nausea and vomiting. Both of those, I don't want to say are inexcusable, because there are times that you do everything you can and your patient's still uncomfortable or they're still nauseated. But we really need to make every effort we can to address their pain concerns. So things you have to think about: what was their pain level at baseline? Some patients start off at 9 or 10 pain, so it's not really a surprise when they have pain afterwards. Other patients are extremely comfortable and maybe very stoic. So for them to say that pain is like a 3 or a 4 is really like a 15 or a 20 for other people. So make sure you've gotten a good evaluation of kind of their baseline status. Like I said the other day, this is also an opportunity to discuss how we're going to manage their postoperative pain. So, is this somebody we're starting off with PO pre-meds? Are we planning on doing IV opioids? Are we planning on doing PO opioids? Are we giving them a multimodal cocktail of medications? Is this somebody that we're going to do some sort of interventional pain procedure to make them comfortable? And then the other thing to think about is what medications are they taking on a regular basis? If you have somebody that's taking large amounts of like PO opioids, it may alter your anesthetic plan. Likewise, you finish that case and they're not breathing quite as well as you want, may not be a good choice to give them naloxone, because you may actually cause withdrawal from their baseline medications. So things like that really need to come into play. We talked about this a little bit earlier, but when we start talking about allergies, think about allergies versus really adverse side effects. So is this something I'm concerned about anaphylaxis happening, or is this something that's kind of normal for that medication? So things you'll see multiple times again. Muscle relaxants are the most common cause of anaphylaxis among anesthetic agents. The most common anesthetic agent that causes it specifically is rocuronium. After that, you'll see that antibiotics are fairly common, and then some of the topical things that people encounter, latex, chlorhexidine, and then opioids are kind of on the back end of things. So patients with latex allergies have become more and more common. A lot of times we see this in our peers and coworkers. Healthcare providers will have latex allergies. So risk factors for that: multiple surgical exposures or an occupational exposure. So like healthcare workers, people that wear rubber gloves, maybe porn stars, I don't know. Food allergies could also cross over. So common food allergies that will trigger latex: mango, kiwi, avocado, fruit, bananas, chestnuts. So if you have somebody that has a latex allergy, make sure, one, everybody knows. A lot of our products now are latex free, but there are some exceptions. Sometimes you will see that it's just a matter of grabbing one type of glove versus another, and they're sitting right beside each other. So if you let people know, it's not a big deal. Some places will put signs on the patient's doorway in addition to like a wrist bracelet, stuff like that. So like I said, big thing is just make sure people know. Other patient populations, you'll see that it's fairly common in spinal bifida patients, or kind of those high-risk kids that I was talking about earlier. And it's probably just because they've had multiple exposures. From an antibiotic standpoint, we talked on penicillin earlier, but cephalosporins are also kind of common. It's a very small risk of cross-reactivity between those. And if it does happen, it's usually a rash. So a lot of times what we will do is give a test dose of those antibiotics to see if they're going to react. This is kind of a dated practice. The reality of the situation is it's not a dose-dependent relationship. If I expose somebody to an antigen, they're going to react either way. It's not, I gave them a little bit and it's okay. So test doses still happen, but it may not be quite as beneficial as we thought. For vancomycin, a lot of times you'll hear people say they're allergic to vancomycin. And what we figure out is it's not actually an allergic reaction at all. It's truly that histamine-induced red man syndrome. So again, go back and ask what happened when they had their allergic reaction to something if you can. Sometimes you get the information, sometimes you can't. We touched on this a little bit earlier with our local anesthetics. Like I said, a lot of times it's due to the preservative PABA. or the epinephrine and the local anesthetic that causes the side effect. So it's not truly a allergic reaction. If you start looking at which local anesthetic category patients are more likely to be allergic to, it's generally going to be esters, and it's due to that PABA. So you might see that again and again. Neuromuscular blocking agents, like I said, rocuronium is the most common that we'll see. But you may have a question where rocuronium isn't an answer, so think about other neuromuscular blockers. Opioids are another one that people will say they're allergic to. A lot of times it's not an allergy, though. They may have some histamine release that results in itching. They may have nausea and vomiting, stuff like that. So drill down to see, are they allergic, or is it just an adverse reaction or a side effect they didn't really care for? So we're going to talk a little bit about some medications to continue or not continue. This is not an exhaustive list. It's just to kind of get you thinking about things. So for the most part, we'll have our patients go ahead and continue any of their blood pressure medicines. The exception to that may be ACEs and ARBs. A lot of times we will discontinue those 24 hours before surgery. And that's because we struggle with the blood pressure, especially in patients that are on lisinopril. It seems to be the worst. Cardiac medications, usually we will continue, specifically beta blockers and digoxin. But most of the cardiac meds, whether it's for blood pressure, rate control, whatever, we want to go ahead and consider that, continue it. If you have somebody that's on antidepressant, anxiolytics, and a lot of the psychiatric medications, it becomes iffy. Part of it is you have to stop and look and see what medications they're on. So if you have somebody that's on TCAs, we may need to get an EKG because a lot of times those medications will cause a prolonged QT interval. The other thing you have to think about when you start holding these medications is how long before surgery you can hold them. Some of these medications have a really long half-life, so holding it for 24 hours may not be adequate. You may have to hold it for a week or two to really get good results. Thyroid medications will usually go ahead and continue. Oral contraceptive pills we try and continue, except in patients that are high risk for VTE, because contraceptive pills tend to increase your likelihood of clotting. So those patients, a lot of times we will hold them 4 weeks prior to surgery. Something for you to think about then, if you have a patient that you've held their birth control, make sure they're aware of that, because next thing you know, they have a baby that pops up during that time period, and they come back and blame you for it. The other thing you will see is some of the medications we use, like Sagamedex, for instance, can basically negate the ability of contraceptive pills to work. So you may have to warn them to use alternative methods during that time period as well. Most eye drops are okay to continue. There are a couple exceptions, and the big thing there is just to be aware of changes that come with it. Sometimes you'll see pupillary changes with eye drops. Other things to think about, medications for GERD, depending on what they're on, you probably want them to continue that as well. But just be concerned, in some of those cases, you may see that their gastric emptying is altered or slowed. So it may make them a little bit more risky for general anesthesia. A lot of times if we have patients that are have GERD and they're to the point of taking medications, we'll go ahead and consider them full stomach and do an RSI. If you have patients that are taking an opioid for pain, please go ahead and consider that. We don't want them showing up that morning in crippling pain because we held their meds. Same thing, we don't want them showing up that morning and seizing because we held their medications. Steroids, asthma medications, continue those. Statins, the recommendations are not quite as easy as some of the other ones. Usually what we will do is stop them about 2 weeks beforehand. But if you have patients that have had a PCI done, have pretty significant ischemic heart disease, we probably want to go ahead and continue those. If you have somebody that's taking COX-2 inhibitors, for a long time, we said to go ahead and hold those medications. And then we turned around and we would give them a dose the morning of surgery. But the recommendations there are not quite as clear. Our biggest concern there is the type of surgical procedure they're having done. So if you have concerns about the bone healing, so say for instance, this is an ortho case, you may want to hold it. But like I said, the recommendations there are not quite as clear. Other things for you to think about, patients that are taking MAOIs, you'll see this is one that frequently pops up on exams and boards. You want to make sure you're not giving them any sort of Demerol. And if you're using ephedrine, you may have to consider a more direct acting vasopressin or vasopressor because the ephedrine may not work. Aspirin, we will generally discontinue 10 to 14 days before surgery, but there is some variability there as well, depending on why the patient's taking the medication. For the P2Y12 inhibitors, same thing. We usually discontinue them a week or two before surgery. If you have a patient that needs to continue those medications, it's okay. But things you need to think about, why are they on those medications? And touch base with the primary team, whether it's their neurologist, cardiologist, PCP, and see what their recommendation is. Something else you can always do is go through and do a platelet function test to see how much those medications have actually altered their ability of their platelets to work the way that they're supposed to. Most topical medications will discontinue the day of surgery. So think about like nicotine patches, fentanyl patches, lidocaine, nitro paste, some of those sorts of things. Part of that is due to interactions in the medications. Part of it is that we don't want to have a metal patch on somebody's chest when we're using electric cautery around them. Diuretics, usually we hold the day of the surgery. If you have somebody that's on like HCTZ, we'll go ahead and continue it though. And again, part of it comes down to how sick your patient is, and really, you know, if you have somebody that you held their Lasix for 1 dose, is it going to be a problem? Or do you need to go ahead and continue it to make sure they're not in pulmonary edema when they show up that morning? Viagra, we'll usually ask them to discontinue 24 hours before surgery if they're taking it for erectile dysfunction. If they're taking it for pulmonary hypertension, we will continue it. NSAIDs, we may discontinue 48 hours before surgery, or if that's what is managing their pain, we may continue it. Coumadin, we usually discontinue about 5 days before surgery. Hormone replacement therapy, same thing as the birth control. A lot of times we'll stop at 4 weeks out to decrease their risk of clotting. If you have somebody that's not on insulin, we may go ahead and discontinue their diabetic medications the day of. This is one of the big problem areas we run into, and we're going to kind of drill into this in a second. But we run into a lot of times issues with patients that are diabetic and what happens in the 12 to 24 hours before surgery. So if you look back historically, we always told people NPO after midnight. So they didn't eat that night, they didn't eat in the morning. And if they were on any sort of long-lasting medication, be it insulin or PO, they would show up that morning and their sugar was in the toilet. Then they wind up getting D50, so they're really high. So you send them on this roller coaster in the perioperative period. The current thought is to maybe consider giving them some sort of carbohydrate-laden beverage that morning. So think about like a Gatorade, so they're still getting some sort of nutritional support, and then have them continue their medications. But it does depend on the medication and the patient. Other times what will happen is we have them convert to a short-acting insulin. So we may, instead of taking Lantus or something that's a little bit longer acting, we'll just go to regular. If you have a patient that's on an insulin pump, we usually go ahead and continue that because a lot of times there's a controlled feedback there where it's actually monitoring the sugar and interacting. If you have somebody that's using one that requires phone interaction, they may be willing to let you have their phone in the operating room, or it may be a matter of you just have to do continuous glucose monitoring on those patients. But there is a fair degree of variability there. If you have a type 1 diabetic, usually we'll cut their insulin dose that morning if they're on long acting. If you have a type 2 diabetic, usually we'll have them hold off on their insulin that day. This was just a quick note I put in here. These couple slides, people seem to struggle a lot of times understanding what's going on in the hypothalamus as far as the how it affects glucose. So I just put these two slides in here to kind of explain things. So a lot of times what happens is we have patients that will be taking steroids, and it may affect the anesthetic management of the patient, whether we need to give them additional steroids or they don't respond to some of our medications the way that we normally expect them to. So we know cortisol comes out of the adrenal gland, but some of our patients are on steroids, which results in an elevated level in the body. So we may need to give them hydrocortisone the day of the surgery, and I'll kind of show you the next slide that's got a clear recommendation for you. Because otherwise what happens, they don't have the ability to respond to stress. So you may see that because of adrenal insufficiency or because their adrenal glands just don't work the way they normally should anymore, because of those steroids, that they don't, when they're stressed or when their blood pressure drops, they're not able to compensate for it. So this is part of the reason we do steroid tapers for patients, is to give their adrenal glands a chance to kind of bounce back. So if you abruptly discontinued steroids, their adrenal gland is not functional at that point, and it takes it quite a while to come back. So that's why we taper steroids. But in the perioperative period, we may need to supplement patients, especially those that have been on steroids, with some sort of synthetic, usually, like I said, hydrocortisone. So this is kind of a guide for you. If you have patients that have been on short doses of steroids, so think about somebody who just got like a one-time dose of Decadron, you probably don't need to worry about them having any sort of HPA suppression. On the other hand, if you've got people that have been on like long-term chronic steroids, so think about prednisone for more than 3 weeks, or they have like physiologic features associated with steroids. So think about like Cushing syndrome, that sort of thing. Those are the people we probably need to consider supplementing them. You can always ask them about the dosing and what they took, but usually we're going to go ahead and make sure that we get them a dose of hydrocortisone, 100 milligrams. This table just gives you an example of different procedures and different recommendations, but kind of the go-to is 100 milligrams of hydrocortisone before an incision, and then you may repeat it if you have hemodynamic issues. So all the things we encounter are not prescription. A lot of times herbal medications and over-the-counter stuff may have direct effects on not only our medications, but also the patient as well. It may alter absorption, distribution, and we see a lot of our patients take some sort of herbal medication. It could be something as simple as vitamins, or it could be something that interacts with their medications as well that they may not be aware of. A lot of times we see patients with polypharmacy, where they're going to multiple doctors that are giving them multiple medications that interact. And it may not be until an independent party sits down and reconciles things that we figure out their problems. So these are just some examples of things. I would make sure I know these, especially the ones with kind of big complications. Ephedra was pretty common. It seems pretty straightforward there, but a lot of times we see people use ephedra as a weight loss drug. Obviously, if they're taking ephedra, we may not see the normal results from using ephedrine. Garlic tends to alter coagulation, as does ginger, as does ginkgo. I just remember that the G medications tend to cause bleeding. You'll see that ginseng's the same way. So they're kind of clustered together. So when you take a look at these medications, figure out a good way to memorize kind of the things that go along with them. These are just continuation. 2 more G's there, ginseng and green tea also cause bleeding problems for you. Kava is not real common in the US, but we will see it as kind of a relaxing beverage. It causes some sedation. It may help a little bit with anxiety. It tends to be a cultural thing. You will see people take palmetto leaves and turn those into a tea as well. St. John's wort is commonly used to help out with pain, anxiety, sleep. So as you would anticipate with something like that, it's going to result in some sedation, delayed waking up. The bigger thing is you see a lot of the metabolism of medications affected by it. Valerian root tends to cause sedation. So this is the actual NPO guideline. And the reason we put this up there is as a community, we're not very good at following our own recommendations. I'm sure when you guys were in the ICU, the kind of standard NPO guideline that you encountered was NPO after midnight. It didn't matter when the patient was going to surgery, whether it was 7 a.m. or 7 p.m. So we did a lot of our patients a disservice by doing that. And that contributed to some of the issues we ran into as far as like wound healing and nutritional status. So this is the actual ASA recommendation for NPO status. So 2 hours for clear liquids. Clear liquids has more to do with the consistency than the actual color. So water is obviously a clear liquid. Most of our sports drinks like Gatorade and stuff like that are a clear liquid. A lot of our sodas, even if they're dark in color, are probably a clear liquid. Black coffee is still considered a clear liquid. If you add milk or creamer or something to it, because it changes the consistency a little bit, we bump that up to the 4-hour mark, like you would see with some of your milks. Same thing with tea, it's a clear liquid. And then juice without any sort of pulp or additional stuff is also clear. Breast milk is generally in the 4-hour window. So when you start thinking about feeding times for babies, something else that comes into play there, if you make somebody NPO or a pediatric patient NPO, you may have to actually provide them with some sort of supplementation from a carbohydrate status. So you may have to put them on like D5 or something like that. The 6-hour meal is kind of like a light breakfast. So toast with juice, formula, non-human milk. So think about your creamer here. And then the coffee with milk figures in here. I think I misspoke earlier. I said with milk added to your coffee, it makes it 4 hours instead of 6 hours. And then 8 hours for a full meal, you know, kind of the big greasy burger or pizza, all those sorts of things. The other thing you have to take into account, this is just a guideline. There are other factors that impact things. So say, for instance, you have somebody that are on like the GLP-1 inhibitors right now are a big topic of discussion because they slow gastric progression. So even though you follow this recommendation, you may see that there's still gastric contents there 8 hours later. But this is the actual recommendation for NPO time. I would make sure you know this because you will see this time and time and time again. And usually the way it pops up is somebody gives you, you know, patient just had a glass of water. How long do you need to delay their case? So part of the reason we talk so much about NPO status is because of the increased aspiration risk. So Mendelssohn syndrome is the increased risk of aspiration. I put this caveat there because, you know, it's kind of straightforward. He came out here and said that, you know, if you don't do these things or you have certain things occur, you're increased risk of aspiration. So if you have more than about 25 mLs in your stomach, a fluid that's a pH less than 2.5, you're high risk for aspiration pneumonitis. So this is really what we want to try and avoid. Things we usually do, try and decrease the gastric volume and acidity. So that makes sense, right? So get it below that 25 mLs and get your pH above 2.5. A lot of times we do this through antacids. So we're raising the pH. We may use H2 antagonists. So ranitidine, cimetidine, famotidine is the most common one we use. They increase the pH and decrease the gastric acid secretion, so that volume goes down. We may use PPIs, but a lot of times these are done on a longer basis because the onset is not as rapid as, say, for instance, famotidine. Most common one we see there is omeprazole and pantoprazole, and they increase the pH and decrease the secretion as well. And then we may also use metoclopramide to decrease the gastric volume, and all it does is increase motility. So things for you to think about here when you're giving these medications, how long they take to work. So a lot of times the sodium citrate or Bicitra works very quickly. It's really the only one that we give in an appropriate time frame. The famotidine or the H2s and the PPIs a lot of times need multiple hours to start working. So giving it right before you roll back with your patient probably doesn't do a whole lot of good. It's something they probably needed the night before or like when they got to the hospital. On the other hand, metoclopramide works fairly fast, but the problem you run into is it tends to cause anxiety in patients. So be very cautious about giving them metoclopramide too far in advance or without something like Versed. Some patients have almost like violent reactions to it. I've seen more than one patient that wanted to cancel their surgery or basically had to be restrained after getting metoclopramide. So I usually will not give that until after I've given Versed. Other things to think about, like I told you earlier, the big dissatisfiers for patients are pain and nausea and vomiting. So think about your risk factors for nausea and vomiting. The most commonly used score is this APFL score over on the right side. So unfortunately for the girls, females are a little bit higher risk for PONV. If you have a history of PONV or motion sickness, you're higher risk. Unfortunately, since most of us have quit smoking, smokers are actually a little bit lower risk of nausea and vomiting. As we get older, we tend to have a decreased risk of nausea and vomiting. Longer surgeries may impact things. And then the bigger thing is that postoperative opioids tend to contribute to postoperative nausea and vomiting. So think about modifiable factors here as far as what causes people to puke. We can't change very many things there other than opioid administration. So a lot of times we try and administer prophylactic medications to reduce the risk. So this kind of shows you where it falls into kind of a stratification. So if I have somebody with no risk factors, that doesn't mean they are totally zero risk for nausea and vomiting. Since it is such a big dissatisfier for patients, I will usually go ahead and give them at least Zofran, and a lot of times I do Zofran and Decadron for everybody. If you have somebody that's 1 to 2 risk factors, they technically need at least 2 drugs and different classes of drugs. So what we mean by that is don't give them 2 steroids, or don't give them 2 5-HT3 inhibitors. Give them a steroid and an HT3 inhibitor. If you have somebody that's high risk, consider avoiding general anesthesia if possible. Or if you do a general anesthesia, consider doing a TIVA because our volatile agents tend to cause nausea and vomiting. So maybe I'll just run them on a propofol infusion. Try and reduce triggers if at all possible. So decrease your opioid use, try and maintain their volume status, a lot of those different things. And there's some more examples over here on the right side that kind of go into a little bit more detail for stuff. This is just a quick overview of some of these medications. So scopolamine is fairly common. It's available over the counter, lots of places. The good news is it works very well. The downside is my personal experience has been the side effects are almost worse than the nausea and vomiting a lot of times. So things you have to think about, it takes a little while to work, so it needs to be applied ahead of time. So usually at least 6 hours in advance. Putting it on that patient the morning of surgery is probably not going to do a whole lot of good for you. The other downside is that it tends to cause sedation, blurry vision, anxiety, confusion. Avoid it in anybody that's got narrow angle glaucoma. But I think the biggest thing people really complain about is that dry mouth. And thinking about it, a lot of times before people become nauseated or start to vomit, they start having kind of that thick, dry mouth. So I think it's almost like causing the same symptoms there. So if I have somebody that's extremely high risk, I will consider a scopolamine patch, but it's not my favorite. I usually do everything else before that. Other things to think about when it's applied, and I try to avoid it in elderly patients because they seem to get the most confusion out of it, which makes sense. A lot of times pregabalin works well to help reduce the risk of PONV. It may just be because it decreases the opioid requirements. So a lot of times I'll either use gabapentin or Lyrica as part of my PO cocktail up front. There are risks with that. Sedation is one of them. Respiratory depression is another. Other things, the most common antiemetic we use is Zofran or ondansetron. When you give it kind of varies depending on your personal preference, but the best time to give it is usually about 30 minutes before the end of the surgery. In most of my cases, if it's a short case, I will give my Decadron and Zofran at the start of the case. I may give a second dose. As far as the dosing, the standard is like 4 milligrams. But if you look at kind of high-risk populations like chemo patients, a lot of times we'll get 20 milligrams of Zofran and 20 milligrams of Decadron. So repeating it is probably not a big deal. So Zofran works pretty well for preventing nausea and vomiting, but it doesn't treat it very well. If you have somebody that's already vomiting, you probably want to look at giving them Phenergan. Cautions with this, again, it'll cause sedation. It may cause some prolonged QT syndrome, which almost all of our antiemetics do. Also, the big thing with Phenergan recently is how it's administered. So most places want you to give it IM, or if you give it IV, it needs to be diluted. And you can also give small doses. We used to give like 12.5 to 25 milligrams of this. You'll see people do just fine with 6.25 milligrams, and then you don't get so much sedation. Like I said, a lot of times I'll give dexamethasone for nausea and vomiting. It also helps out with pain. I generally try and give it after the induction of anesthesia, one for kind of covering my post-operative issues as opposed to giving it very early on where it may wear off. But the other thing is don't give Decadron to awake patients, or if you do, give it very slowly. If not, you'll be in for a surprise. It tends to cause a severe perennial burn-in. Other things to think about, Decadron in your diabetic patients may be problematic. So just evaluate how brittle they are, and you may decrease your dose from like 8 milligrams to 4 milligrams or something like that. We touched on this, but develop a decent pre-medication plan for your patient. Commonly, like I said, we'll give gabapentin or pregabalin ahead of time. We may also give Celebrex or Tylenol. A lot of our patients will wind up getting antibiotics for surgical procedures. If you're giving an antibiotic, it usually needs to be given within 1 hour before incision and no sooner than 15 minutes before cut time. If you're using something that has to be administered a little bit slower, like vancomycin or a fluoroquinolone, a lot of times it's within 2 hours. And these are just some common antibiotics and dosages. You guys will get this a little bit more in depth in pharm. Like I said, cefazolin is the most common we use. We are starting to use cefazolin in conjunction with clindamycin or Flagyl to get a little bit better coverage because we're starting to see more resistant bugs coming along. So we're using multiple antibiotics for them. Vancomycin is most commonly given for resistant stuff, or think about it for almost your big cases that are a little bit more higher risk for infection, especially like abdominal cases or thoracic cases. These are just kind of some standard doses for you. I would make sure you know these because you'll probably see them again and again and again and again. And then finally, something you have to think about for this whole process is all the things that have to come together to make it work. A preoperative clinic can accomplish a lot of these things, but I think it's important for us to remember that this isn't a battle. We're not trying to beat out the surgeons. All of us want the same things, but sometimes our egos get in the way of being productive and doing what our patients really need. So if you have a preoperative evaluation clinic, I think it really helps out. It decreases costs because you don't have cancellations. Patients are happy. Surgeons are happy. You're happy. Patients have better outcomes. They get maximized and optimized before they get to the operating room. So we don't have to worry quite as much about patients not being prepared for surgery. So I think preoperative evaluation clinics are really the way to go. Like I said the other day, depending on what you want, that clinic can mean a whole lot of different things. It doesn't necessarily have to mean a formal structure. It can just be you calling your patient the day before. And then this is just kind of an overview of how that whole process works. All right, what questions do you guys have?